Hey everyone, Sean here. So every time we dispense medicines, we don't just pass the medicines to our patients, we also give them guidance on what they can do when situations become difficult. And one of the examples that we have here is with a group of medicines called SGLT-2 inhibitors. They are diabetes medicines. You should already know their names, dapagliflozin and empagliflozin, canagliflozin. Now, these medicines help to lower blood sugar levels by making patients pee out more glucose in their urine. But here's something interesting. So, unlike most diabetes medicines, we actually tell our patients to stop taking these drugs if they become sick and then restart once they recover. So, why do we do this? Why is this medicine treated differently compared to the other diabetes medicines that we have studied? Well, the short answer is because SGLT-2 inhibitors can hide a life-threatening complication called diabetic ketoacidosis, or DKA for short. And this is made worse when the patient falls ill. Now, it does this by increasing the risk of euglycemic diabetic ketoacidosis, and this means that the person's blood sugar level is normal or near normal, but in the background, ketone levels are rising to a very, very dangerous level. So that's the short answer. The longer answer is always more interesting, and it's something that, in my opinion, every pharmacy professional should understand. So let's break it down. Now, I call this your reserve power because this is a deeper layer of knowledge that gives you the foundation for the advice that you give your patients. Now, it gives you a deeper layer of understanding of why we tell our patients what we tell them, and this makes us professionals. For the newer ones in our industry, having this deeper layer of understanding will give you confidence when you tell your patients something, rather than just memorize it from a set of notes. So firstly, we're going to talk about what exactly is diabetic ketoacidosis. Secondly, if we say that the detection of diabetic ketoacidosis is a problem, then we need to know how to detect diabetic ketoacidosis. Thirdly, how do SGLT2 inhibitors complicate things even if our patients are not sick? And finally, how being ill makes everything worse. So the main cause of diabetic ketoacidosis is when insulin levels drop too low, and this causes the blood to become very, very acidic, dangerously acidic. So let's see what happens first during low insulin levels, and in this case, loosely termed normal hyperglycemia. So we know that for patients who have hyperglycemia, there is increased insulin resistance and therefore increased blood glucose levels. What are we talking about? We know that insulin is the key that unlocks the cell to allow glucose to enter the cell, right? If glucose doesn't enter the cell cannot use glucose for energy. Now, when insulin levels are low, there aren't enough keys to open the doors, and therefore less glucose enter the cells and more stay in the blood vessel. We call this insulin resistance. Now, when more glucose stays in the blood vessels, this results in high blood sugar levels or hyperglycemia. Hyper means high, glycemia means blood sugar levels. So other than insulin moving glucose in the cell, we also know that insulin can block a process called lipolysis, which means that it blocks the breakdown of fats for energy. And this makes a lot of sense because especially after a meal, when there's lots and lots of glucose, energy storage is the priority, not energy release. Energy release will be the priority when a person is under a fight or flight reaction, like running away from a pack of wolves. So we'll come back to this later. So the next incident that we are going to explore is what happens when insulin levels are very low. So when insulin levels are very low, two things start to happen. The first problem is dehydration and electrolyte balance. So what happens when blood sugar level becomes very high? the body tends to get rid of excess glucose by passing it out in the urine. And as glucose leaves the body, it pulls water along, and water follows. So when more glucose leaves the body, more fluids leave the body. Now this leads to a lot of fluid loss. And when there's a lot of fluid loss, the patient becomes dehydrated, and electrolytes like sodium, potassium can drop to very, very dangerous levels as they are lost together with that fluid. The second issue is with the increased production of ketones. So when there is low insulin, glucose cannot enter the cells because remember, insulin is the key to unlock the cells. No insulin, no key, and the glucose stays outside of the cell, in the bloodstream. When this happens, the body thinks that it is starving for energy, and when the body is starving for energy, it tries to find another source of energy, in this case, fats. So the body tries to break down fats to give itself energy. When fat is broken down, it produces byproducts called ketones. Now, ketones are acidic, and when too much of ketones build up in the body, then the blood becomes acidic. So this brings us to the term ketoacidosis. So acidosis is because the blood level acidity rises. Keto because it's caused by an increase in ketones. So what's the problem with high ketone levels? So firstly, the blood becomes very, very acidic. More acidic than the body can cope. So with large increases in ketone levels, the blood becomes acidic, the balance is now totally off. Certain things happen in the body, enzyme function is affected, cell metabolism is affected, organ function can be affected as well. Now when ketone levels are high, there is an increased risk of severe dehydration through two things. So firstly, the high blood sugar levels result in the body trying to get rid of that glucose through the urine. So we've discussed that. When sugar goes, water will follow. More sugar gets in the urine, pulls more water, and therefore increases fluid loss. But also, the body knows that ketone levels are high, and it tries to get rid of the ketones by flushing it out in the urine. Now this worsens the dehydration even more. Now when there is increased urine, electrolytes like sodium, like potassium get pushed out of the cell into the bloodstream, right, resulting in very, very high blood potassium levels or hyperkalemia. Now this can result in an increased risk of arrhythmias or irregular heartbeats. Finally, there's going to be stress on some organs. Now the heart is affected because of the potential of arrhythmias, the brain is affected, the patient might get confusion, nausea, coma. The kidneys are affected because they don't clear these acids well, which means that the blood remains more acidic and the acidosis is worsened. So when we combine both things, we now have hyperglycemia or high blood sugar from diabetes plus acidosis from ketones. And then we get the full picture, diabetic ketoacidosis. So now that we know how diabetic ketoacidosis can be life-threatening for a patient, we need to know how to detect diabetic ketoacidosis. So normally detecting diabetic ketoacidosis is quite straightforward. We check for two things. The first thing we look out for is high blood glucose. In most patients with diabetic ketoacidosis, sugar levels are really high. Now the second thing we check for is ketone levels. Now elevated ketone levels normally confirm that acidosis is developing. So it's usually the combination of high sugar and high ketones that help us diagnose diabetic ketoacidosis. But here's where things get a bit complicated, because what happens then if blood glucose levels are normal but ketone levels are high? So that's a tricky situation, because for us as healthcare professionals, we might miss this indicator of high ketone levels and put our patients at risk, especially when they are on SGLT-2 inhibitors. So now that we know what is diabetic ketoacidosis, why it is a problem, how to detect it, we now need to understand the role that SGLT2 inhibitors play in this mess, even in a patient who does not have the additional stress of illness. Now the short answer is because SGLT2 inhibitors increase the risk of euglycemic diabetic ketoacidosis. What does this mean? So let's quickly remind ourselves of how SGLT2 inhibitors work. Normally, the kidneys reabsorb glucose from the urine back into the blood. SGLT2 inhibitors block this reabsorption, and when the reabsorption is blocked, more glucose is lost in the urine and blood sugar level drops. Now, on the surface, this sounds great, but the lowering of blood sugar levels by SGLT2 inhibitors can actually cause some hidden problems. Now, we know that it can result in a release in a loss of glucose in the urine, that's its MOA, and therefore a normal blood glucose level. But when the blood glucose level looks normal, some patients tend to use less insulin. Since insulin blocks lipolysis, the breakdown of fats, we know that with less insulin, there is more breakdown of fats. When you have more breakdown of fats, you have more ketones, and ketones increase the acidity of the blood. And then we have increased glucagon release. Glucagon actually tells the liver to release more sugars from storage because we want to increase the amount of energy source available. So blood sugar level increases. It also increases the breakdown of fats to supply more glucose. More fat breakdown means more ketones. So we end up with this very unusual picture where the patient's blood sugar level looks normal, but their ketone levels are getting higher and higher and higher. That's why it is called euglycemic diabetic ketoacidosis. EU means normal, like in the brand Euthyrox, which means normal thyroid levels. But in this case, it's normal glycemic levels, normal blood sugar levels, but with diabetic ketoacidosis. And that's why SGLT2 inhibitors are unique, because other diabetes medicines do not mask high ketone levels behind a normal looking glucose level. Only SGLT2 inhibitors do this because of how they work in the kidneys. Also, other SGLT2 inhibitors work to either reduce or they don't even have any effect on ketone levels. Only SGLT2 inhibitors can cause this increase. So finally, let's talk about how illness makes everything worse. Now, when a person falls ill, the body tends to release stress hormones, right? There are 3 different stress hormones. The first one is cortisol, the main stress hormone. Cortisol increases gluconeogenesis, means that the liver produces more sugar. It also decreases the uptake of glucose in muscles and fats. This creates insulin resistance. So when there's insulin resistance, glucose doesn't go into the cell, it stays in the blood, increasing the risk of hyperglycemia. And then we have adrenaline. Adrenaline, also called epinephrine, is the classic fight or flight hormone, right? It breaks down glycogen, right, in the liver, which causes a quick release of glucose into the blood, and this increases the blood glucose levels. It also reduces how well insulin works because the priority during a fight or flight reaction is to release more sugar, not to store it. And more importantly, adrenaline increases lipolysis, the breakdown of fats into ketones. With more lipolysis, we have more ketones. With more ketones, we have higher acidity. All right, and the reason why the body does this is because the body is trying to release energy to be able to survive. And then there is glucagon. Glucagon has a similar effect. It promotes gluconeogenesis. It breaks down glycogen in the liver, right, to release more glucose for energy, and it increases lipolysis to increase more ketones, which results in more ketone release. And more ketone release means increased blood acidity levels. So during illness, patients are already at a much higher risk of producing ketones. And if they continue to take an SGLT-2 inhibitor, the blood sugar level will look normal because it's actually being flushed out by the urine, but the ketone levels keep climbing higher and higher and higher in the background. So with the effect of these stress hormones, you have adrenaline and glucagon that increase ketones, combined with in the fact that with SGLT-2 inhibitors, you increase ketones and glucagon again increases ketones, you perhaps have the perfect storm for euglycemic, which is normal blood sugar levels, but diabetic ketoacidosis, which is a life-threatening situation that could go missed by a healthcare professional. So now we finally answer the question that we started with. Why do we tell patients to pause SGLT-2 inhibitors when they're sick and then to restart it when they recover? It's because illness increases ketone production through stress hormones. The SGLT-2 inhibitors mask this danger by keeping blood sugar levels looking normal, and even when the ketone levels are dangerously high. Right? And the ketone levels are high because of both the SGLT-2 inhibitors and the stress hormones. So when you tell a patient to stop the medicine during illness, you remove that masking effect, and we lower the risk of euglycemic diabetic ketoacidosis. Once the patient has recovered, is eating well, drinking well, then the stress hormones will settle down. It's safe for the patient to restart the medicine. So the counseling point goes: pause when sick, restart when well. And the next time you counsel a patient on their SGLT-2 inhibitor, remember this, because your explanation could be the key that protects them from very, very serious complications. Okay, and remember, while the medicines we dispense are very powerful, very effective things to help a patient, it's the knowledge behind them and how we communicate the knowledge that inspires patients to take care of their health and to cope with difficult situations, might even save their life. Love you guys, keep going.